I'd be more than happy to. There was a whole bunch of stuff that happened this morning, and there wasn't a lot of time for questions. So I'm actually fine with taking questions that people may have, especially Hep C questions. If people have Hep C treatment questions, Christopher and I can try to figure it out. We don't have Susanna, but because I felt like maybe there were some questions that people had, or Hep C cases that co-infected cases that they might have a question about. So please don't be shy. Also, if you have a specific HIV case that you're interested in hearing discussed, I'm sure they're more interesting than what I'm going to show you. So any residual questions from Susanna's talk today? Nothing. It's so clear. Kara, thank God.
So for those of us who work in a 100% Brian White funded clinic in a rural setting,
right,
we don't have a way to send our patients to private centers.
Right.
And I'm not sending them anywhere for a liver biopsy because we can't pay for it either.
Right. So
in those patients, how do you, other than the free score, how do you get you can't get a good assessment of fibrosis? Is that okay?
Well, I think it's certainly okay from the point of view of well, okay. So the concerns are there's kind of financial concerns about can you get it paid for versus kind of clinical concerns. To me, the only real clinical concern is that you might treat someone that has decompensated cirrhosis or has cirrhosis severe enough that you'd want to do that in conjunction with a hepatologist. And so I don't think you really need a score for that, right? I mean, you can figure that out, I'm pretty sure.
But so the patients for F3, F4 maybe, they're asymptomatic. I guess my concern is how do you follow them long term if you don't know the level of fibrosis after you cure them of their
yeah.
We have a request for you to repeat the question.
Oh, okay. So the question really has to do with if you're in a clinical setting where you cannot assess fibrosis other than with a FibroSure or an AST platelet ratio score, how do you know how to follow those patients? I mean, obviously that question is kind of independent of whether you treat them or not, right? Because if they have cirrhosis, obviously you need to follow them. So I don't have a particularly good answer to that one. I do think that the issue of potentially taking patients who are at risk of decompensation, I think that's a clinical assessment, and you can make that one. And I'm sure you don't have any qualms about if someone has cirrhosis clinically. And I don't know. I mean, I think if you have someone who has a completely normal platelet count and a normal AST and you cure them, do I think they still need an ultrasound every 6 months? No. But that's just my opinion. And I don't think there's a specific guideline for that. Christopher, what, I mean?
No, I would agree with that. I think that the key is that, Susanna didn't mention it in her talk, but in other talks she's mentioned that with a biopsy, you always add one. So you assume that it's a really big liver and you're getting a really tiny piece of it, and that you should always add one to the score. So if it's F3, you should assume that there may be cirrhosis present. If it's F0 or F1, you're probably good to go. With the fibro scanning, you're getting the whole liver. But it's, again, as she said in her talk, it's better for cirrhosis versus none, rather than trying to divine if it's F2 or F3 or F4. So really, the F3 is good for a blunt tool to say cirrhotic or not. And then if they are cirrhotic, that puts you down a whole other pathway of care where really that person should get connected to a hepatologist at whatever referral place is closest to you, somebody that's confident in dealing with somebody with cirrhosis, in helping you manage full hypertension and other things. So, it's not a really good way to serially follow people.
Yep. Okay. And we haven't really gotten any specific guidance, and I missed the first part of Susanna's talk about people who are cured, how obviously they have less risk. There's no question that they have less risk of decompensated cirrhosis, they have less risk of HCC. But as far as I know, if someone has cirrhosis, nobody's relaxed any guidelines in terms of follow-up screening, though potentially, I suppose they may over time. Any other questions, clinical questions, treatment questions, Hep C? I don't have any Hep C cases, but we can have as many as you want if you bring one up. I'm going to go through a couple of cases that I think are pretty challenging. So if you have a question that of clarification, please feel free to interrupt. You're welcome to interrupt at any time here. These cases are designed to try to engender discussion. There's no clicker. There's no ABC clicker. But there are questions before we get answers. So this is a case. It's stylized, but it's after one of my patients who presented several years ago. So it's time updated for things that we don't do anymore or treatments we wouldn't use anymore. But so she's a woman who was diagnosed recently because her husband, as it turned out, was diagnosed with HIV after a hospital admission for pneumonia. In my patient's case, it was her recently ex-husband. She had never previously been tested. She was moderately obese. She had clear GERD on therapy. She had type 2 diabetes, but relatively well controlled, hypertension, and she came to me with a history of osteopenia by DEXA, not osteoporosis. She had one male partner. She did smoke, no alcohol, no other substances, and is unemployed. And here are her medications. So she's on esomeprazole once a day, amlodipine once a day. She developed cough on lisinopril. She's on metformin, 1,000 milligrams twice a day, and she's on calcium carbonate and vitamin D. So not that unusual of a person. And you have to decide whether you're going to treat her and what you're going to treat her with. My patient's BMD was not 36, so, but somehow I typed 36. Her blood pressure was not perfectly well controlled. She did have some very modest peripheral neuropathy, basically tingling. She had a normal creatinine, normal ALT. She was A and B immune, hepatitis C negative, B5701 negative. This is her CD4. Her viral load was 54,000, and her genotype showed no resistance, and she's very anxious to begin her treatments. Okay? So, questions to discuss. And you guys are, they're fellows here, so it's good, because that takes the pressure off some of us older people who have to come up with the answers. Any additional tests that you guys would like? You can get whatever you want, but tests that would be germane to what you might do for her. Parker, you're required to answer now.
Just further evaluation, I don't know if there was extra treatment with or your analysis.
Good. Great. Yep. Yeah. Yeah, I think we've got most of the tests that we want. Lipids, I would also get in her. I also would want to know what her hemoglobin A1C was, just in part to kind of get a sense of how she's doing with the therapy that she's supposed to be taking. Her blood pressure is a little high, but perhaps. So this is an open question, right? So who can recite the now 5 recommended regimens in the DHHS guidelines? No, don't recite them. How many of the 5 are integrase inhibitor containing? And Chris got 4. 4 of the 5 recommended regimens contain an integrase. The only one that isn't is darunavir, ritonavir with tenofovir FDC. There are no NNRTIs-based regimens now anymore in the guidelines as at least recommended regimen, which is, I think, somewhat startling, and we could argue about that for a while. But one question that comes up, since 4 of the 5 choices are going to contain an integrase inhibitor, do you need to get integrase inhibitor resistance? Anybody here from Charlotte? I know that in Charlotte, for sure, you get a GeneSure Plus, so you get integrase inhibitor resistance as part of your standard resistance test. At UNC Chapel Hill, we don't. We don't get an integrase test. I don't know what they do in Greensboro.
Not part of the bundle thing.
Right. Do you get it for treatment-naive patients? Are you doing that?
Although I guess there's data that there's not much conversion.
Yeah. Who actually orders it? Chris, do you get an integrase? You get it in Wake though, because you get GeneSure Plus, right? Yeah. Yeah. Anybody consciously check it off consistently in treatment-naive patients? I don't think it's necessary personally, because I think we're well below 1%, but the CDC is screening, and I think it's, you can make an argument, since we're going to be starting most people on integrase inhibitor, it's a relatively modest test in terms of expense. And since your first regimen is the one that's least complicated, most likely to be successful, and least likely to have toxicity, you might not want to blow it, and it may be that it's worth the $200 or $300, or if you're lucky and you live in Charlotte and work at Wake County, you just get it. Yeah. How about at Wake? Have you seen transmitted integrase resistance? So in treatment-naive patients, and are you keeping track? You haven't seen it? I know you see it in experienced patients, because I talked to Robert the other day. Yeah, so it's certainly something worth keeping track of, whether we're seeing integrase. There are some integrase polymorphisms, so not all things that say decreased susceptibility on an integrase genotype will actually probably impact therapy, but that's relatively subtle. Okay. So which of the DHHS recommended regimens would you consider for this patient? I forgot what. So here they are. So the list is really shrunk. And there's a lot of debate about why it's shrunk and should it have shrunk this much. I think what I've heard people talk about is that when the list was actually 10 different regimens, people felt like they were guided as much as they should be by a guideline. And instead, these are regimens that could be, there are no caveats here. I think there's a couple of caveats in terms of what you need to know before you treat somebody, which is obviously if you're going to use a bacavir-containing regimen, you want to know if they're HLA-B5701. But there's no HIV-related characteristics that would keep you from giving any of these therapies to any treatment-naive patient other than resistance testing. And obviously, you need to know someone's renal function in order to properly dose medications. And in order to use a bacavir, you want to be HLA-B57. So there's no, well, if their viral load's too high, if their CD4 is too low, that sort of choice. There really are, based on HIV characteristics, any one of these regimens would be reasonable. There are a series of what are called alternative regimens, and I think the most important thing here is they are clearly preferred for some people. And so there may be reasons why you would use one of these alternative regimens. Multiple of them used to be in the kind of recommended list, including the 2 NNRTIs previously were in the recommended list. Rilpivirine, though only for lower viral load or higher CD4. And then atazanavir, ritonavir, of course, was previously a recommended regimen and is now an alternative regimen. So there are reasons you might consider that. So what drug-drug interactions are you worried about? I'm looking for... Okay, so let's go back. So what Andrea, what are you worried about? So you're on amlodipine? What's the problem with amlodipine? So cobicistat or ritonavir will boost levels of amlodipine. What else? PPI. What PPI? Proton pump inhibitors are going to mess with which drugs? Either recommended or alternative? rilpivirine, right? So rilpivirine for sure. Atazanavir also, though atazanavir you can probably negotiate, you can probably manage. What else is on here that is going to give you a drug-drug interaction? More subtle. Metformin and dolutegravir, what happens? Doubled. Metformin levels are doubled when given with dolutegravir. So you need to pay attention to that. There's one more here. The senior clinician in the group. That's okay. Calcium carbonate. What's wrong with calcium carbonate? Right, it'll chelate integrase. And so I actually looked at all the different package inserts. I don't think it's in the package insert for ritonavir. For dolutegravir, if you're going to take your dolutegravir on an empty stomach, don't take it with calcium carbonate. On the other hand, if you're going to take your dolutegravir on a full stomach, you can take it with your calcium carbonate. Otherwise, you need to separate it. In general, what I tell people is it's probably better to separate, though calcium carbonate and iron are not that big a deal. On the other hand, the liquid antacids like Mylanta and aluminum-containing antacids should clearly be separated from integrase inhibitors, regardless of what the package insert says, any of the integrase inhibitors, because they actually bind to the drug and lead to the drug being inactive. Okay, so I think we covered them. So what are we choosing? Her CD4 is 250, her viral load's 54,000. She's got multiple comorbidities. She's a smoker, she's got hypertension, she's got diabetes. Kara, what are you giving this lady? You can choose an alternative one too if you like. It's totally fine. She's 54, right? Her creatinine's normal, 1.1, but she has diabetes. Okay, who's choosing something different? So if you give her dolutegravir and she comes back, she goes to her nephrologist a month later, and her creatinine is 1.5. When the nephrologist sees her, are you worried or you're not worried? Yeah, Michelle's not, but the nephrologist is, right? Because, right, the creatinine can go up anywhere from 0.1, which no one might not notice, but could go up by 0.4. With dolutegravir or with a cobicistat-containing regimen, that would be the L-vititegravir regimen. So when a patient is being managed by multiple clinicians, it's an issue because their calculated creatinine clearance is going to change. Their clinician may adjust their other medication doses without understanding the problem. I was very proud of myself. On Thursday, I had a patient no-show, so I created a smart phrase in EPIC. It's this big log thing about what happens to creatinine. It even has a little drop down in the middle where you can pick which drug you started. It's really nice. I'll share it with anybody. So, you could almost make a case for raltegravir here, I think. She's already on a bunch of BID medicines. We got a 10-year history of safety of raltegravir. Doesn't change creatinine. Wouldn't be wrong. I think people want to be on a single tablet, but she's already on multiple medications. I don't think there's a wrong answer up here. Kara, I think, was perhaps equivocating a bit because we still don't know whether abacavir is associated with myocardial infarction or not. We do know in an FDA meta-analysis that if you looked at patients randomized to abacavir versus randomized to something else, predominantly as initial therapy, there was actually no increased risk of myocardial infarction in the meta-analysis. In fact, the point estimate was right on 0, or no effect. But unfortunately, in large clinical trials, most of the people are 30, 35. Most of them don't have diabetes, hypertension, smoke. And there are quite a bit of observational data that would suggest that abacavir is associated, at least recent use of abacavir is associated with MIs. So I think that's where Kara and I are kind of like, this lady, if you did her AHA risk thing on your I think it came out to like 13% for her, depending on whether she was smoking or not and how well her blood pressure was controlled. And we didn't, I made up a cholesterol because I didn't have it. So, and at least in some of the epi studies, they suggest that the hazard with abacavir is twofold. So does that mean her risk would go from 13 to 26% 10-year risk? I'm not sure that's true. That seems like an exaggeration to me. But I think it gives us, some of us, a bit of pause. Christopher, would you consider any of the alternative regimens here? Yeah. If she wasn't on a PPI, would you consider Complera? Are you? Her viral is 54,000. She's probably likely to be quite adherent. Okay. Any questions about this case? Anybody would do something entirely differently? Karen?
Is there a reason to avoid tenofovir?
Yeah. So here. But are there any drug interactions that you're concerned about? What alternative or other regimens would you consider? And would you discuss any modifications to her diabetes or hypertension? So let's, yeah, because I'm going to address your question in 1 second. So let's say you decide with dolutegravir, tenofovir, FTC, modifications to her diabetes therapy. Yeah, I would probably lower the metformin. That's why I would like to know what her hemoglobin A1C was, especially if it was pretty well controlled. I would want to do that. If you chose the darunavir, ritonavir initial therapy, you could certainly try. I'm not sure why she wasn't given losartan or another ARB as opposed to an ACE. She had a cough to an ACE. Probably most people would say. So you could certainly use an alternative antihypertensive. And depending on how bad her GERD was and how much you wanted to use rilpivirine, that you could potentially modify that. And you'd have to talk to her about how to take her calcium carbonate. So it's not easy. But I think what makes it harder, oh, did I screw this up? This one makes it harder. So it's the same patient, except now she has stage 3 chronic kidney disease. CKD is 45. So then I think it's quite a bit, the case becomes quite a bit harder. I think with a normal creatinine I would use tenofovir. I don't know, I missed Christopher's talk this morning. I don't know if you mentioned anything about therapy and okay, so by the fall, and certainly by a year from now, we will have alternatives to tenofovir that may have something called TAF, tenofovir alafenamide, which it's not certain, but certainly suggested that it will have less renal toxicity. So for patients whose creatinine clearance is normal, like hers, even though she has a lot of renal risk, I would have felt fine with a TDF with a creatinine of 1.1. In this setting, I think it's not at all straightforward what to do. I think this is a setting where you really have to think hard about how much myocardial infarction risk abacavir really carries. And you might consider that here. The DHHS guidelines for the first time actually list 2 regimens that don't contain 2 nucleosides in their other category. They list lopinavir, ritonavir 3TC, based on a study called GARDEL, G-A-R-D-E-L. I don't know why it's called GARDEL, where lopinavir, ritonavir plus 3TC was compared to lopinavir, ritonavir 3TC plus a third nucleoside, mostly AZT, some D4T, and some tenofovir. And it was not only non-inferior, but it was slightly numerically better even in high viral load settings. So that would be potential alternative here. You'd have to be, I think you'd want to be pretty confident that you could trade the lopinavir, ritonavir for a better boosted PI. In the past, I would have been said, oh, no problem, don't worry about it. But I'm a little less sure. The other regimen that is in the other category, again, for patients in whom tenofovir or bacavir would not be you would not select tenofovir or bacavir as part of the therapy, is darunavir, ritonavir, and raltegravir. So a kind of nuke-sparing regimen. Again, would it be okay to give the dolutegravir instead of raltegravir so it's all once a day? It's not been tested. It seems like it would make pretty good sense. But it also seemed like that particular regimen would have been terrific, and it's not terrific because at high viral load or low CD4, there are some virologic failures. And when you give darunavir, ritonavir, raltegravir, and you have virologic failure, darunavir, ritonavir no longer protects its partner. So most failures on a boosted PI, not only do you not see boosted PI resistance, but you usually don't even see nucleoside resistance. But in failures of darunavir, ritonavir, raltegravir, you actually saw raltegravir resistance in some of the failures. So it's not. This is a really hard decision, I think. You could even argue, well, maybe I'll give the tenofovir every other day and wait and pray for this new alternative. I think in this setting, I'd probably use a bacavir-containing regimen. I would probably use dolutegravir, abacavir, 3TC, and monitor her quite carefully. Do everything I could to get her to stop smoking, control her blood pressure better. But I think that's a tough decision, Michelle. I don't know. Yeah, probably. Not been tested. You'd think it would, right? And it's generic, wouldn't be that expensive. Yep. Yep.
I was curious about, I'm not sure about the
No, speak it real loud so everyone can appreciate your question. I'm sorry, instead of talking around the microphone, people just.
Yeah, I was busy mumbling. My question was about dose adjustments of like lamivudine and how much of a concern that is for you all. I personally been dosing like Tridimec, for example.
I would have been fine with. I mean, that's outside the package insert. Purple alert. CME. Blah blah blah. I would have been fine with a creatinine clearance of 45 to use 300 milligrams a day of lamivudine. I think it's a good point. Okay, great. We're almost done. I'm sorry about this. So this is second line. So this is kind of straightforward, but I think not necessarily as clear, or not necessarily as simple as it might seem. So this was is still a 35-year-old African-American man who has sex with men. He was diagnosed in 2009, had a lowish CD4, a highish viral load, wild-type genotype. He also had hepatitis B, and his hepatitis B DNA level was very high, which is pretty typical. He had essentially a negative past medical history and wasn't on any medication, except there was a history that he used methamphetamine about 8 or 9 years previously, but he hadn't for the last 8 years, and he was employed and was interested in starting on therapy. So at that time, which was 2009, he was started on efavirenz tenofovir FTC, had an excellent response, and came for follow-up consistently, and his CD4 did what it was supposed to, and his viral load was less than 40. However, towards the end of the year before last, he missed his last appointment, and then in June of a year ago, give or take, he had an HIV RNA of 10,000 and a CD4 of 450. Unfortunately, around the time of New Year's, he went to the wrong street corner, or the wrong party, or met the wrong friend, and started using methamphetamine again. So that was New Year's in 2014. So now it's 6 months later. It's June of last year, and he's got rebound viremia. When his partner threatened to leave, he was able to stop, or at least he was able to get his life together. He wasn't currently using methamphetamine, but he admitted that during much of early 2014. He was intermittently adherent. He says he restarted taking it consistently 2 months ago. Again, we're in June 2014. But his viral load is 10,000, and the C4 is somewhat lower than it was. So next steps. So this is like, these are easy first steps. So what do we do? We get a resistance test for sure. People have asked me, well, do you tell them to stop his Atripla while you're waiting for the resistance test? I would say it doesn't really matter right now. I mean, just get the resistance test and move kind of quickly. Other things you're going to do? Hep C, excellent question. Yeah, sure. He's obviously been kind of potentially been sexually active while using methamphetamine. You might get a Hep B DNA level also. You might even consider getting Hep B resistance test, though resistance to tenofovir and Hep B is very, very, very uncommon, so you might not need to do that. So this is his genotype. I don't think anybody here would be surprised by that. K103N, M184V. No other mutations. You were fortunate enough to live in Wake County, so you also got a GeneSure Plus, so you also know he doesn't have any integrase resistance. You wouldn't expect it because he hasn't been on an integrase, but now you know. So now, what are you going to consider for this patient? He's off. He has a clear urine tox. He's been off methamphetamine. He's back to work. His partner comes with him. They're supportive, but obviously he just had a period of kind of chaos in his life. So what therapy would you consider for this patient? First failure, kind of very typical 103 and 184V. Blair.
Amy and I would like to send him to Katie Cooper.
Yeah, he actually met with, this is again kind of is Katie in here? This is kind of a stylized version of one of my patients who actually came to Katie Cooper first. He bypassed all us medical people and said, I need Katie. Katie Cooper's our social worker who is specializes or has particular skill in substance use. So this guy went straight to her. He bypassed us. So he's in care, substance abuse care. Amy, what are you doing? What are you going to give this guy?
Can you tell me what his Hep B viral load?
Remarkably, his Hep B viral load is only about 1,000. It hasn't rebounded dramatically. His AST and ALT are normal. Well, I don't know. I mean, yes. I mean, on the surface, yes. Yes, he's back at work. He's with his partner. He's in therapy with Katie Cooper. Yes. But it's the best we can do. Uh-huh. Right, so that's what I'm trying. I'm bugging you about that. Okay, so that's exactly what the question I'm after. Good. So let's say you're daring. You're daring. Amy, typically not daring, by the way. If anybody wants to know.
No, I'm back to the PI.
So if you were to use dolutegravir, let's say in this setting, and that's the only PI I would use this is the only integrase I would use in this setting. Well, it depends on what other drugs you're going to give. If you're going to use dolutegravir, what else would you give with him? He just has 184V. Right? Absolutely. Right. He gets tenofovir.
I think I struggle with that. I mean,
Sure. We all do.
I know. I come to you and probably, or David, and I say, where would you get someone else? I don't know.
So to me, the question really is, and the guidelines have finally come around, right? The guidelines have always said, and they still do, and they forgot to fix the box, which I learned the other day. The box still says at least 2 and preferably 3 fully active agents. But actually, if you read the text, it no longer is that adamant. In fact, the text would allow you in this setting to use 2 fully active agents and 3TC or FTC, though the guidelines clearly suggest that one of the fully active agents should be a boosted PI. So I think what Amy's telling us is that what she would probably do here is darunavir, ritonavir, darunavir, cobicistat maybe atazanavir, cobicistat, plus tenofovir FTC. I think the open question is whether dolutegravir, tenofovir FTC would be okay in this setting. And I don't know the answer. Christopher?
The only other consideration is that there are reports of overdoses with methamphetamine users with ritonavir.
Ah, good point.
It can boost the level of and duration of exposure to methamphetamine. So that's a consideration if you think he's high risk for relapse. I'm assuming it does.
Yeah, cobicistat, you mean? Yeah, I think so. Again, this is kind of the concern that Christopher had, which is a really good one, is that patients who are on boosted protease inhibitors, ritonavir-based or cobicistat-based, may be more likely, will have higher levels of methamphetamine potentially if he goes back to using methamphetamine. And in fact, if he'd been on a efavirenz-based regimen, which he was on, he may be used to having to use a little bit more methamphetamine, perhaps, than in fact, the patient who this is stylized on actually was on a boosted PI, but I wanted to get one, and he actually kept saying, I'm such a cheap date when I go on methamphetamine, because he only had to use a little bit. He couldn't figure out why, and then we figured it out. So Christopher's exactly right as usual. So the question is whether dolutegravir has the kind of resistance barrier chops to handle 2 fully active. Presumably there's no tenofovir resistance, so I guess you don't know for sure. There might be some. Does it have the same kind of pharmacologic and genetic barrier to resistance that a boosted protease has? And nobody has the answer to this question, though I think some people would feel comfortable. I would not use elvitegravir in this setting, and I would not use raltegravir in this setting, because I think it's very clear that they do not have the same pharmacologic or genetic barrier to resistance as a boosted protease inhibitor. That's 100% clear. So.
Could you use the ritonavir methamphetamine interaction as a way to help him stay clean?
I don't know. I don't know.
I think that the danger is that
The question was whether making the patient aware of that interaction would perhaps help him stay clean.
the issue is the availability of really ultra-pure methamphetamine. So the imported stuff, the stuff that people cook is crap. So if you want to start on methamphetamine, get the good stuff from Mexico, and that purity can be street pure as 100%. And that's rare among street drugs to be that pure, but it can be. So depending on who you get, you could have way different PK response to that.
Go ahead.
Yeah, just change the scenario up a little bit.
Sure. Do what you want.
The person has been off the regimen for, say, 2 months, 3 months, 4 months, 4 months. Does that change your getting a phenotype?
I was hoping for a longer question. I would say no. It just changes how I interpret the answer. I mean, if it was a $10,000 test, I'd probably not get it. But since in the relative scheme of things, it's a relatively inexpensive test. But then I would only use the positive information. But you could imagine, right, that if you got, let's say he was off, and you got a resistance test, and you actually saw a 65R, that would really change what you were going to do, a tenofovir resistance mutation, right? So I would definitely get the test. I mean, if he said he'd been off for a year, probably not, but if it was a few months and he was taken intermittently, I would do it.
The monogram makes this archive GenoSure thing, which you have to be careful about whether the insurance company of your patient will cover it or not. I believe Ryan White will cover it.
Huh.
But that's not a nice test, and that'll deep sequence your
So what Case is talking about, probably everybody knows this, but through Monogram LabCorp, you can actually send your patient's cells. You have to get a different tube, a different sample, but they actually look within the peripheral blood mononuclear cells of your patient and look at HIV DNA and look for archived mutations. So that may be a way to get more sensitive information. It's, I think, been mainly talked about in scenarios maybe not so much like this, but maybe a patient who you don't have a really good treatment history, they're on a odd or complicated regimen, and you think, boy, I could simplify. Maybe you would get that test there. But it's possible someone off therapy for a year with a complicated past history, it could be useful. But I would put the same caveat on it, which is, you only know if you see something, it's probably useful. If you don't see anything, I would not assume with that test or that meant, oh, it's fine. For if someone had a past history of treatment failure on let's say, I don't know, indinavir from way back when, and you did that test and you didn't see any protease inhibitor mutations, I would not feel confident about I would be very cautious in my selection of therapy. Okay, so and then this really is a question for Christopher and anybody else, Katie, but she's not here, is how would you monitor this patient after restarting? Let's say you're brave and you go with dolutegravir, tenofovir FTC, or darunavir, ritonavir FTC, either one. So kind of two fully active agents and a either 3TC or FTC. I would actually monitor this patient very carefully, much like a new start. See them within 2 to 4 weeks, and then probably see them pretty frequently after that. In part, you don't necessarily have to spend an hour with them, but if they're going to spend time with Katie or at a group or whatever, to frequently get their virus load to HIV RNA to make sure that they stay suppressed, and if they do start to rebound, to be able to respond to that quickly. Would it be wrong to give this guy 3 active agents? So would it be wrong to say, you know what, I'll give tenofovir, a boosted PI plus etravirine or rilpivirine or an integrase. So give 3 active agents. I don't think that's wrong. In fact, the guidelines still talk about ideally 3 active agents. I do think it makes for a more complicated regimen, and potentially, if adherence is at all a problem, it could make that problem worse. But I think most people would be comfortable in this setting to use a boosted PI plus tenofovir FTC, and some people, I think, are considering using dolutegravir in that way, but maybe not. There's certainly no good evidence for that yet. There are some data from a study called Sailing, where integrase-naive patients were randomized to get dolutegravir versus raltegravir, and there was a suggestion that the patients who got only dolutegravir and nucleosides, despite being substantially treatment experienced, actually did very well. That was not a randomized comparison. That was a subset. It was a relatively small subset. But there's certainly some information out there. So I think I'm going to have to stop. This case I stole from Christopher and changed it around a bunch. But we'll do this one quick, because this has got a really important point, and then we'll end. So this is a man. I have no idea what he looks like, actually. But I made him fair-skinned. Who was on atazanavir, ritonavir, tenofovir FTC, and he wanted to have his therapy simplified. And it looked good, right? His HIV RNA was less than 40. His CD4 was 450. No other medical problems, no other medication. His creatinine was 1.3. It was 1 several years ago, but his bilirubin was 4. He had excellent adherence, good insurance. He'd been followed in our clinic for 6 years. Actually, Christopher didn't follow him. He corrected the problem. And all of his HIV RNAs were below detectable limits, every single one. And he seemed like a perfect candidate, and he really wanted his therapy simplified. He has too many pills. He was looking a little yellow. He's got some creatinine creep. He's on atazanavir, which we know is associated with some renal dysfunction. So what additional information do you need? HLA-B57, okay, so it's negative, good. This is like a trick. What else do you want to know? Had he ever been treated before, perhaps? So it turns out he was diagnosed in 2001. His CD4 at that time, these are totally made up, but they seem good, was 168. His viral load was 500,000. He was in an ACTG study at a nearby site that will go nameless. He got efavirenz and other medications, but he doesn't remember exactly what. And he stopped all his therapy at the end of the study and was kind of out of care for a while. But then several years later came back and got on atazanavir ritonavir with tenofovir FTC. And he says, I was a different person. I can tell you the 6 times I missed my dose in the last 8 years. And he knows. And you believe him. So now what? He wants to be simplified. What are our choices for simplification? He wants to go to. So he could go to atazanavir cobicistat and tenofovir FTC. That would simplify from 3 pills to 2. Wouldn't change very much. He'd still have a bilirubin that was elevated, and he still might have some increased renal risk. What else? What other alternatives here? Michelle's not giving him a triplet. Excellent. I wouldn't give him a triplet either. It's a little shady on what happened to him at this other institution in the early 2000s.
I'd be worried about I would want to use a PI or dolutegravir, I think. With a higher area of resistance, not knowing what
Right.
resistance history is, absent the GenoSure archive or something that give you more information.
So Case has obviously been doing this for a long time and thinks very carefully. So we don't actually know all the details, and some of those details I gave you were garnered in retrospect, and Christopher can correct me because I might be a little off here. But what we do know is the patient was treated with a fixed-dose combination of elvitegravir, cobicistat, tenofovir FTC, which, given that he'd been suppressed on therapy, hadn't missed any doses, but looked great for 6 years, probably seemed pretty reasonable. But I think this is about when Christopher saw him. He was suppressed for a short period of time, and then at 6 months, however, he was no longer suppressed. And you get him right back in, you repeat, it's the same viral load. Now what? And just so we don't miss our next speaker, now what was really kind of, I think, remarkable. So he had a 103N, which he probably got, as Michelle said, from his efavirenz. This is only dinosaurs have this mutation. This is a 69 insert. There's looking for someone old enough to know about this. That was a mutation that was selected for predominantly by either sequential nucleosides, DDI in the mix. We surmised, I think, in the end that he was probably on ACTG 384, which was a randomized trial of efavirenz versus nalfinavir. And then they either got DDI D4T or AZT3TC. These were probably present before, and that compromises all nucleosides. So this guy was basically kind of on atazanavir ritonavir, sort of monotherapy. Maybe nucleosides have some mystical activity. I unfortunately probably selected for 184V with the more recent therapy, and unfortunately also selected for integrase resistance. So getting that history is absolutely critical. And I totally agree with what Case said, that if you're worried about previous virologic failure, some of these simple therapies that look really attractive are probably not quite as attractive. And so you need to be careful. That was the point of this one.
We had an identical patient like that.
Really?
I didn't make the change to Stripe-L, but we saw the same progression.
Is that right? Yeah. Anyway, lesson learned. All right. Thanks, everybody.